Thank you very much for the opportunity to present an overview of our study today on behalf of my colleagues in the Children's Oncology Group. Our abstract is entitled Genetic and Response-Based Risk Classification Identifies a Subgroup of NCI High-Risk Childhood B-Lymphoblastic Leukemia with Outstanding Outcomes. Refinements in risk classification have contributed to overall improvements in ALL outcomes. Risk groups at diagnosis determine treatment intensity, identifying patients at higher risk of relapse so treatment can be intensified, and also importantly, identifying patients who do well with less intensive therapy to minimize acute toxicities and late effects. This is a schema for the Children's Oncology Group ALL-03B1 study. This was a study that was conducted to provide a mechanism for real-time disease classification and also for specimen banking in all children, adolescents, and young adults who are newly diagnosed with acute leukemia. Children at the time of their diagnosis of leukemia entered the protocol, and then they initiated an induction treatment regimen based on their age and white blood cell count along with their disease immunophenotype. At the time of diagnosis, they underwent testing for prognostically relevant cytogenetic findings, and this was done in Children's Oncology Group approved cytogenetic laboratories. We know that the rapidity of response has been important in past studies, so this was assessed by doing just morphological routine exams in the bone marrow on days 8 and 15 at local institutions, and then bone marrow was sent to 2 dedicated Children's Oncology Group reference labs for flow cytometry-determined minimal residual disease detection at the end of induction. All this information was then integrated at the end of induction, and children were classified into one of 4 risk groups: low risk, standard, high, or very high risk group for subsequent post-induction treatment allocation, and then their risk group assignment was manually entered into an electronic database for providing treating physicians to see. This trial was conducted from 2003 to 2011 and accrued over 11,000 patients. The majority of those enrolled on companion therapeutic protocols and had information that was interpretable and could be used for their risk assignment. The focus of this presentation is on the B precursor patients or B lineage patients, and there are about 8,000 of those patients. Patients with very high-risk features, so that would have been anyone with an induction failure, extreme hypodiploidy, or the BCR-ABL fusion, did not continue on the treatment protocol after induction, but their outcomes were captured. Very similar with past studies, the distribution in standard risk patients in high risk was about 2/3 of patients were standard risk, 1/3 high risk. The majority of children, 3/4, were less than 10 years of age. There was a male predominance, and the vast majority of children had a presenting white count less than 50,000 and no evidence of CNS disease. The rapidity of response, as shown in past studies, was highly prognostic in this study as well. This shows the 5-year event-free survival rates on the left and overall survival rates on the right. And for the 84% of patients who were deemed rapid early responders, they had statistically significantly better event-free survival and overall survival rates compared to those who were slow early responders. Outcomes also have varied according to cytogenetic subsets and ranged from about 70% in those with unfavorable lesions to 95% of those with favorable lesions. This is looking at aggregate data for both the standard risk and high risk patients together. And one thing that I'd like to point out is among the favorable cytogenetic subset groups of patients, their 5-year overall survival rates exceeded 98%. If we look closer, we were intrigued by the outcomes in this favorable cytogenetic group and wanted to understand the contribution of their risk group as well. So on the top is the NCI standard risk patients with favorable cytogenetics, on the bottom the high risk patients. One thing to point out is, regardless of having favorable cytogenetics, those individuals who had end induction MRD values of greater than 0.01% had inferior outcomes, so that was still a prognostic marker. Then one thing that we were pleasantly surprised to see was that among the NCI high-risk patients, those who had very rapid MRD responses, so less than 1% at day 8 in the blood and less than 0.01% in the marrow at day 29, had a 94.9% 5-year event-free survival and 98% overall survival. We wanted to see if the same pattern would hold true if we broke this group out according to their ages. And among those less than 10 years of age, which was 44% of the patients, compared to the greater than 10-year-olds, there were not statistically significant differences in their outcomes, although the numbers here are smaller, as you can see. So in conclusion, real-time classification incorporating clinical features, blast cytogenetics, and early response was feasible in close to 10,000 patients enrolled on COG-ALL clinical trials and identified patients with varying outcomes for risk-based treatment allocation. Early response by marrow morphology was not prognostic when MRD response was used, and therefore is no longer used in our current generation of protocols. While favorable cytogenetic features were not prognostic in NCI high-risk B-ALL patients in prior studies, outcomes for this subgroup who have no evidence of CNS leukemia and who are also rapid MRD responders are excellent with contemporary therapy and suggest that these patients will not benefit from further chemotherapy intensification. I'd like to conclude by acknowledging particularly my study co-chair, Mignon Lo, and many other colleagues from the Children's Oncology Group. Thank you for your attention.